In this video, I will demonstrate how to calculate measures of sensitivity, specificity, and likelihood ratios. Typically, we use these measures when we're trying to evaluate the accuracy and the usefulness of a diagnostic or evaluative test or some sort of measure. So examples of this might be a test that we use to diagnose the presence or absence of a certain illness or disease or condition. We could also use tests to evaluate the presence of a characteristic or a trait, like level of depression, or whether or not someone's depressed or not depressed, personality traits, or level of some kind of performance. For example, having a certain level of reading comprehension or critical thinking, or even having kind of a criterion of a pass or fail of a test, or having a certain level of physical performance like running speed or fitness level. So when we have a new test that we develop in order to diagnose or evaluate any of these characteristics, one of the things we need to do is evaluate how effectively it does what we think it does. So if we're using it to try and diagnose an injury or a condition, we want to make sure it can actually accurately diagnose the presence or absence of that condition. So these measures help us understand a little bit better how accurate and useful this test may be. So we'll start out defining what each of these measures can tell us in a basic way, and then we'll get into a little bit more in-depth detail of what each measure can tell us as we go through an example of how we can calculate these. So the first measure we can talk about is sensitivity. And this basically tells us how accurately the test can correctly diagnose the presence of the condition or trait that we're interested in. So if we're trying to diagnose an illness, can the test accurately tell us if the condition or illness is actually present? Specificity, on the other hand, gives us an idea of how accurately the test can correctly diagnose the absence of a condition, or basically to rule out a condition. So can this test tell us if this person does not have the illness that we're trying to evaluate? And then likelihood ratios give us an idea of how well the test can improve our ability to make a correct diagnosis. So without a diagnostic test, we basically could flip a coin to decide if a person has or doesn't have an injury or a condition. So we have basically a 50% chance of being correct without any other kinds of diagnostic tools. But if we have a diagnostic test, what we want to try and find out is how well this test can improve our ability to make the correct diagnosis, to kind of take us beyond flipping a coin or having a 50% chance of being correct. Now, the positive likelihood ratio gives us an idea of how well the test improves the correct diagnosis of a condition that is present. So does this improve our ability to make a diagnosis of a person having a condition? Now, a negative likelihood ratio is how well the test improves our ability to correctly diagnose the absence of a condition, or in other words, to rule out whether or not someone has a condition. So positive likelihood ratios are related to the sensitivity of a test, and negative likelihood ratios are related to the specificity of a test. So we very often will use the combinations of these measures to determine how accurate the test is, as well as how useful the test might be. So we're going to go through an example of how we would evaluate a hypothetical test that can help us diagnose whether or not someone has a certain type of hip injury. And again, this example could be used for many different types of diagnostic tests or evaluative tests, but I'm using this example because this one is similar to, I think, a lot of people could relate to. So this test is called the Malarkey test, and this test is designed to try and diagnose whether or not someone has a hip injury, and more specifically whether or not someone has cartilage damage on the inside of their hip joint. So how we would begin to evaluate this Malarkey test to see how accurate it is we need to compare its performance to a criterion or reference standard or a gold standard. So how this would work is we would gather a group of people that Some have a hip injury, some do not have a hip injury. And what we would do is perform the Malarkey test on these group of people and keep track of whether or not the Malarkey test says they have or don't have the injury. And then we would have those same people go through the gold standard test, which in this example might be surgery, where we actually do a surgical procedure and go ahead and evaluate the presence of the injury in the hip joint. And so that would be the gold standard. Now, in order to do this evaluation, we need a gold standard that we can compare the test that we're designing to. So in this case, what would happen is we'd evaluate these people on the Malarkey test, and then we'd follow that up by evaluating them using the gold standard. And then we'll be able to compare the accuracy of the Malarkey test to the gold standard to see if they agree. So if the Malarkey test is accurate, we should get very similar results to what we would see with the gold standard. So when we evaluate these kinds of tests in this way, we have 4 possible outcomes that could occur when we compare the Malarkey test to the gold standard. And so the first is what's referred to as the true positive result. And this is where the Malarkey test, when we perform it on a patient, tells us that there is a hip injury present. In other words, it's a positive test. And then when we do the surgery or the gold standard on that same individual, the surgery tells us that yes, there is injury present. So the Malarkey test and the gold standard would agree. And this is known as a true positive result, in which the two tests are agreeing that there is injury. Now the next possible outcome is known as a false positive. And this is where the Malarkey test indicates that there is an injury present, but when we do the gold standard or do the surgery shows no evidence of that injury. So in this case, they do not agree, the gold standard and the Malarkey test. Now the next possible result is what's known as a true negative test, and this is where the Malarkey test indicates there is not an injury, and then when the gold standard is performed, the gold standard also indicates no injury. So in this case, the Malarkey test and the reference standard agree that there is not an injury. Now the last possibility is known as a false negative, and this is where the Malarkey test indicates a negative result. In other words, there is no injury, according to the Malarkey test. And then when the reference standard is performed, it finds that there is the presence of an injury. So in this case, the Malarkey test and the gold standard do not agree, and Malarkey says no injury, gold standard says there is an injury. So basically what we're looking for, and we would like to see, is that the more accurate and the more useful the diagnostic test is, the higher the number of true positives and true negatives will be present when we test it, compared to the number of false positives and false negatives. So if a test is accurate, it's going to consistently be able to tell us that yes, this person has the injury when they really do, or no, this person does not have the injury when they really don't have the injury. And so the measures that we're going to calculate are basically looking at the proportions of these true positives and true negatives compared to the false positives and the false negatives. Now the next step in evaluating the Malarkey test and calculating out these measures is we need to actually have our data and have it organized for us. And so typically how we would do this in SPSS is we would have 2 columns of data. One column of data would be the results for our individual people on the Malarkey test, and it's typically going to be dichotomous. They have or don't have, they have a positive test or a negative test for Malarkey, and so all that data would be in one column, and then the column next to that, the second column, would be the results of the gold standard or the reference standard, in this case surgery. So the results of whether or not they do or don't have an injury would then be placed in that column. Okay, we would then produce a cross-tabulation table. We would run a cross-tabs analysis using these two variables, and it would produce a table like we see here on the slide, where in the rows would be the results of the Malarkey test, and the columns would be the results of the gold standard or the reference standard. So as you can see in the first row, first column, we had 38 subjects in which the Malarkey test was positive and the gold standard was positive. So these are our true positive individuals. In the second row, or bottom row in first column, would be the people that had a negative Malarkey test but were positive for the reference standard. So these would be people that are false negatives, and we have 8 people in that case. If we look in the first row in the second column, these are the people that had a positive Malarkey test but a negative gold standard test. These are our false positives, and we had 12 of those. And then our last cell, we can look at the people that had a negative Malarkey test and a negative gold standard. Those are the true negatives, and we have 42 of those. So that's what our cross-tabulation table data would look like, and that gives us a sense. If we just look at this, we get a sense that it appears we have more true positives and more true negatives compared to false positives and false negatives. So on the surface, it appears that the Malarkey test is doing a pretty good job of accurately diagnosing the presence or absence of the hip injury. Now the next step will be to actually perform the calculations of sensitivity, specificity, and likelihood ratios. And there's 2 ways to approach this. If we run the kappa level of agreement test in SPSS, and I have another video on the site that shows how to do this kappa agreement test, it will use a cross-tabulation like we see here, and it will give us specificity and sensitivity numbers automatically. But in order to calculate likelihood ratio, we need those 2 values. So in this example, I'm going to go through the calculations by hand just so you can see how these are done. And you can see that how we calculate sensitivity, specificity, and then likelihood ratios. So our next step then is to actually calculate sensitivity and specificity. So just to kind of review real quick what each of these is telling us. And here's our cross-tabulation table. Again, here's the results that we see. And then in just a second, I'll go over the formulas here for sensitivity and specificity. So first of all, sensitivity, again, is how likely is a test to produce a true positive outcome. That's the sensitivity. So in other words, how well does the test identify individuals who have a hip injury relative to the reference standard? So we also often refer to this as the true positive rate. And it is basically a proportion or percentage of positive test results relative to the actual number of gold standard positive results. Okay, so as we look at this formula in sensitivity, we can see here it's basically a ratio between the number of true positive results and then the number of true positive results plus the number of false negative results. We take this denominator, true positive plus false negative, divided into the true positive values. And we can see here are our values. So we had 38 true positives, we had 8 false negatives. We do the arithmetic and we'll end up with a ratio of 0.83. And we typically convert this to a percentage, so in this case it would be 83%. So what this is saying then is the Malarkey test was able to accurately diagnose the presence of a disease 83% of the time. Now typically we like this to be as close to 100% as possible, but typically when we have something in the neighborhood of 80 to 90%, that's considered to be quite good. Now specificity, on the other hand, gives us an idea of the true rate of true negatives and designates the ability of the Malarkey test to correctly diagnose patients without the hip injury. So as we look at the specificity formula, we can see it's again a ratio, the number of true negatives divided by the number of true negatives plus false positives. So we had 42 true negatives, we had 12 false positives. We do the arithmetic, and again we can see we get a ratio here, and we can convert that to a percent, and so we have a specificity of 78%. So again, what we can say here is that 78% of the time the Malarkey test correctly diagnoses the absence of the hip injury. Now ideally we'd like a test to have high levels of sensitivity and specificity, and so it's going to be able to confirm and or rule out the presence of a condition at roughly the same rate. But when we're weighing the benefits of one measure relative to the other, the type of condition that we're trying to diagnose might have an influence. So a high level of specificity, for example, is more likely to be able to rule out a condition. And if we're dealing with a life-threatening condition, for example, the ability to rule that out quickly might have a priority relative to a high level of sensitivity. So if, very often when we're dealing with emergency situations, we want to be able to rule out a life-threatening situation as quickly as we can, and then we can go on and deal with that individual. Now, on the other hand, a high level of sensitivity indicates the test is more likely to identify the presence of a condition, and therefore it helps strengthen our diagnostic or evaluative conclusion for a particular condition or trait. And then this may result then in being able to use fewer other techniques to help confirm a particular diagnosis or characteristic. And so we sometimes have to kind of think about that is, do we want the test to be more specific or more sensitive? And it really does depend on the situation that we're in. But ideally, we'd like them to be pretty equivalent and as high or as close to 100% as possible. Okay, so now that we have sensitivity and specificity, we get an idea of how accurately the test can rule in or diagnose the presence of a condition, as well as rule out or diagnose the absence of a particular condition. So the next step then is the likelihood ratios. And we're actually going to use the sensitivity and specificity values to calculate these likelihood ratios. So again, just to kind of summarize here, the likelihood ratios give us a quick measure of how much the test improves the likelihood of making a correct diagnosis as either a true positive or a true negative. So as I mentioned before using a diagnostic test in a testing situation, there's a certain level of probability that the test will correctly diagnose the condition. Okay, pre-test probability. And depending on the condition and situation, that probability is around 50%. So again, I could just guess to say yes they do or no they don't, and 50% of the time I would be correct. Now sometimes this might be a little higher or a little bit lower depending on the situation. So a useful test, a test that is useful to us, will be able to shift the probability of a true positive or a true negative result away from that pretest probability. So if the pretest probability is 50%, a useful test will shift that probability away from 50%. So if it's useful, that shift away from the pretest probability will indicate how likely a condition exists after a true positive and how likely a condition does not exist after a true negative. So ideally, a test will shift the probability of a true positive result higher than 50% or towards 100%, and shift the post-test probability of a false negative lower than 50% or towards 0%. So we want to have false negatives 0% of the time. We want to have true positives 100% of the time. So when a likelihood ratio is calculated, the closer the value is to 1, the less of a shift there was in the probability that the condition is or is not present. So let's go ahead and go through the calculations here, and we'll talk a little bit more about how to interpret these. So let's do the positive likelihood ratio first. And so the formula here is the sensitivity value divided by 1 minus the specificity value. So our sensitivity value was 0.83 and our specificity value was 0.78. So as we do the calculation, we get a positive likelihood ratio of 3.77. So the larger that number is, the larger the positive likelihood ratio is, the greater the shift in post-test probability. In other words, the more likely it is this test is going to help us come up with a true positive result. Okay, we'll talk a little bit more about the interpretation in just a minute. Now let's look at the negative likelihood ratio. That formula is 1 minus the sensitivity value divided by the specificity value. And so as we plug those numbers in, we come up with a negative likelihood ratio of 0.22. Now in this case, it's kind of the opposite of what we want to see happen in the positive likelihood ratio. We want to see a negative likelihood ratio that is very small, as close to 0 as possible. So again, a positive likelihood ratio, we want to have it be larger than 1, much larger than 1 if possible. And then in a negative likelihood ratio, we want it to be as close to 0 as possible, or much smaller or lower than 1. So there's 3 general ways we can interpret these likelihood ratios. The first is the shift in probability, or the change of the likelihood ratio value relative to 1 is large and high. So in a positive likelihood ratio, if we have a large shift that creates a high or large positive likelihood ratio value, there's a strong certainty the test made the correct diagnosis that the condition is present. So we get that improved true positive rate. Now, another possibility might be that the shift in probability is very small or uncertain, and so a more decisive test is probably needed to produce a true positive or true negative result. So if we have a very small positive likelihood ratio number, then it really didn't improve our probability of coming up with a true positive. Now, for the negative likelihood ratios, if we have a shift in probability that is large and low, in other words, towards 0, there's a strong certainty the test made the correct diagnosis that the condition is not present. Now, we can also have the same thing happen in a negative likelihood ratio where the shift is small. In other words, there's very little change from 1 towards 0. And so that would mean the probability is uncertain, and a more decisive test would be needed to produce a true negative test result. So, therefore, to again summarize, a high positive likelihood ratio value indicates a high probability the test produced a true positive. And a negative likelihood ratio that is small or low indicates a high probability the test produced a true negative result. So let's look at this table here, and this kind of again summarizes what we can look at with these numbers. So in this first column we see positive likelihood ratio values, and then in this column we see the negative likelihood ratio values. So let's start at the bottom. So if we have a positive likelihood ratio that is close to 1, or a negative likelihood ratio that again is close to 1, this is a very small shift in probability, and so this is probably not a very useful test. As the positive likelihood ratio values increase, as we get to 10 or above, that would indicate a large shift in probability and probably a very useful test. As the negative likelihood ratio values get smaller, in other words closer to 0, that would also indicate a large shift in probability and probably a very useful test. So again, to summarize, a positive likelihood ratio indicates the level of confidence we have after performing a test that a condition is actually present when a test result is positive. In other words, the true positive result. So the greater the value of the positive likelihood ratio, the more likely we will get a true positive result. Now the negative likelihood ratio is, you can think of it as kind of the opposite. This indicates the likelihood that a condition is present in a patient when the test indicated it is not present. In other words, we have a false negative result. So if the negative likelihood ratio is close to 1, then a false positive result is more likely to occur. But if the negative likelihood ratio is close to 0, then a true negative result is more likely to have occurred. So to summarize, we can use sensitivity, specificity, and likelihood ratio values to determine the usefulness of a test. And in our example, our malarkey test, we had fairly high levels of sensitivity and specificity, so close to 80% or a little bit above. So about 80% of the time, this malarkey test will be able to correctly diagnose the presence or absence of a test. When we look at the likelihood ratios, however, we had a fairly small positive likelihood ratio. If we go back to our previous slide, we had a positive likelihood ratio of 3.77 and a negative likelihood ratio of 0.22. those both fall in this range, and so there's a small shift in probability. So this test could sometimes be useful in diagnosing the hip injury condition. So we might need to use other diagnostic tests in conjunction with it to kind of confirm the presence or absence of that condition. So hopefully this gave you an idea of how we can use sensitivity and specificity and likelihood ratios to evaluate a diagnostic test. And if your research involves in trying to validate a diagnostic test of some kind, then these are measures you'll definitely have to use. So hopefully you learned something from this presentation, and good luck using this in your own research.